across the Atlantic. Is Dr. Ruparel here? Yes, there she is. Do you want to come and sit on the stage? We haven't met before, but I know your talk's going to be brilliant. I'm Roger Kirby, and I'm the chairman of this session. And we're very lucky. We have a brilliant faculty here. We have my buddy Cuddy Carson from North Carolina, my brother Mike Kirby, and we have Dr. Mamta Ruparel, who's just arriving on the stage right now. So my job is to set the scene and tell you about the trouble with men. And as the audience, mainly male audience in here today will know, men are actually a mobile disaster area. They are their own worst enemies. And really the thesis of this 1 hour is to persuade you that urologists have an important role as custodians of men's health. We can encourage earlier presentation. We can counter this concept of toxic masculinity. And by doing that, we can help reduce premature deaths. Well, it's been known for some time that men's life expectancy is about 5 years less than women, all ages, and there are different reasons for that. It was originally thought that it was something intrinsic to men, that they naturally died 5 years before their female partner, but it turns out that quite a few of these things are actually avoidable, and we're talking now today for the next hour about how to avoid these issues. So what is the trouble with men? Well, they're risk takers, especially young men. They're more susceptible to cardiovascular disease. They have a higher mortality for most cancers, obviously prostate cancer. They drink alcohol more heavily than women. They smoke more cigarettes for longer than women, and Mamta will be telling us about that. They're subject to depression and other mental health issues. They're more susceptible to AIDS and die more frequently from AIDS. And many men have unhealthy lifestyles, lack of exercise, and a poor diet. 3 out of every 4 suicides are male suicides. Women often attempt suicide, but they often fail. Men, if they attempt suicide, they're more likely to succeed. I guess that comes back to sort of risk-taking behavior. Well, this is a slide of a blood cell infected by the AIDS virus, and it makes the point pictorially that men are more susceptible to this disease, especially in sub-Saharan Africa. And of course, the culprit behind these men's health issues is this molecule, testosterone, which results in a number of issues. You know, males tend to have problems with dominance and with aggression. The two are linked together. They repress their emotions. It's been shown that men who are concerned about their manliness are about half as likely to seek preventive health care compared with those who are concerned. Men often deny their own feelings, and in doing that, they deny those of others with, not surprising, resultant relationship issues. This is the kind of typical male. I put that up as a plug to my daughter's next movie. You'll be able to catch that on your screens on the 2nd of August. The Rock there is kind of typical macho man. You'll see him leaping out of aeroplanes and so on the 2nd of August. So, you know, the attitudes of men can be encapsulated by a constellation of Ds. They're in denial, so that results in delayed diagnosis. They subject themselves to danger. They have a rubbish diet, particularly red meat and carbs, as Julian Shah demonstrated when I had lunch with him half an hour ago. They drink, and when they drink, they are subject to violence, accidents, as well as liver disease. They take drugs, they become depressed, and eventually all of these things are compounded and encapsulated in a very expensive divorce, as illustrated by quite a few of my colleagues. So, you know, men are obsessed with sex, as everybody knows. You'll see from this video.
I think the organisers have done a brilliant job tonight, getting so many people from all sides of the business to attend. I think it's important for the purchasers and suppliers to meet face to face so they can make the personal bond.
No, I'm not at all interested in anything you've got to say, I'm afraid. I'm a very important man. Now, you are a very attractive young lady, and it's nice to have you here for decorative purposes. But you're not very important, so I can't be bothered to talk to you. Do you see? Unless, of course, your father or husband is important, in which case I would be prepared to patronize you for a few minutes for the sake of your important connections.
Right. Well, I'm not married, and my father's unemployed.
Well, there you are, you see. You're a very attractive waste of time. Oh, unless, of course, you want to sleep with me. I am a very important man, so it would be...
So, yeah, I think that, unfortunately, he's standing for Prime Minister right now. And he does typify some of the aspects of male health problems. So why do men seek healthcare? You know, the three principal reasons: they have trouble with their lower urinary tract, LUTs. They have anxieties about prostate cancer, often hyped up by outfits like Prostate Cancer UK or Tough. And they complain of bothersome sexual dysfunction, which not infrequently is associated with BPH.
Mr. Griffin, I'm just going to need you to drop your pants and we'll check your prostate.
What?
Drop your pants, turn around, and lean forward.
Okay. So how's this work? You just feel my pulse, so... What the hell was that?
Mr. Griffin, that's a prostate exam.
Shut up! You had your finger in my ass!
That's how a prostate exam is performed.
So, yeah, men not only are reluctant to present for all sorts of reasons, issues related to sexual function, but they're keen to avoid clinical examination. So just taking up some of these issues, I was relieved to see this paper published in the New England Journal of Medicine, having had prostate problems sorted for me 5 years ago, that early prostate diagnosis can result in increased lifespan. Some of our colleagues are not so lucky. Poor John Anderson developed prostate cancer, developed metastases. He was the best president of BAUS that we never had because he got poorly just before he was able to take up his post, having been voted for it. And this is Peter Remington, another example of how rubbish men are at looking after themselves. He came cycling with us in South Africa and didn't take any notice of his blood pressure or his cholesterol level, ended up having a myocardial infarction and a stent in his left anterior descending branch. He was really lucky to survive thanks to coronary care in Eastbourne. So cardiovascular deaths, you'll be hearing more from my brother Mike about that. They actually are higher risk to men than cancer deaths, as you can see on the total number there. The risk factors for coronary artery disease are similar to those for erectile dysfunction. So clearly urologists need to understand the links between erectile dysfunction and cardiovascular disease. And again, we'll be hearing about those in more detail. In fact, diagnosing coronary artery disease isn't that difficult. It's controversial, but you can see the plaque there sitting on the left anterior descending branch of some unfortunate patient. And you can see the calcium deposited there. So the use of a coronary artery calcium score, a CT scan that only takes about 10 minutes to do, can be quite a reasonably accurate screening test for coronary artery disease. And it's something that urologists need to think about. A very good NPV, as you can see there. And if the score is very high, then they should be offered either a CT or possibly an invasive angiography. And intervention at that stage, that early stage, before the precipitating angina and myocardial infarction occurs, obviously has some benefit, and it's something that we should be discussing with our patients. There's an issue with red meat. You know, red meat is associated with manliness. Real men eat red meat, but it's been shown that 70 grams, that's 2 rashers of bacon per day, increases your carcinoma colon risk. Red meat's linked to global warming, water depletion, deforestation, and animal cruelty issues. So cutting back on red meat would be some good advice, because none of us wants to get a colon cancer illustrated there. Again, something we could discuss, something that I used to discuss with my patients, the possibility of having a CT colonoscopy, a virtual colonoscopy, which is much preferred to a regular colonoscopy and much better tolerated by patients. So this is Michelangelo's David from the Renaissance. This, unfortunately, is the current Michelangelo. Too much of American fast foods there. No insult intended to Cully Carson from America. But the risk of too much fast food is this hazardous waste. as you can see there, and we'll be hearing from Mike about lifestyle, about the pathogenic cycle from inflammatory cytokines and leptins producing these cardiovascular risks. So I remember very clearly sitting in a restaurant in Wimbledon with Cully, drinking red Italian wine, rather nice wine, and we came up with this mnemonic of getting to a better place. Portion control, lose the booze, axe the snacks, cut the carbs, and exercise every day, and avoid eating hamburgers like that. And I actually hand out that leaflet to my patients, telling them they need to get to a better place and they need to eat a much healthier diet like this one of pulses and green vegetables, etc. And then another issue is alcoholic liver disease. The red graph there is the increase in alcoholic liver disease deaths over the decades. You know, there's no question that men, perhaps even especially urologists, drink more than is healthy, and cutting back on alcohol has got to be a good thing. Doing more exercise, you might recognize some of these cyclists in front of the Angkor Wat temple in Cambodia, cycling for tough, but getting men to do more exercise, encouraging them to live a healthier lifestyle is clearly something we should do, because there's no doubt that physical inactivity is linked to cardiovascular risk, and you can see the stats there behind that. So when patients present with erectile dysfunction or indeed LUTS, we need to think about all these issues that Mike will go into in more detail. The tip of the iceberg, this is one of Mike's slides. And we need to think ED doesn't just stand for erectile dysfunction, early detection, education, endothelial dysfunction, and possibly early death. That was Graham Jackson came up with that rather nice slide illustrating the problem. So urologist as a men's health doctor, you know, what we should at least consider is checking the waist, measuring BMI, pulse, lipids, hemoglobin A1C, blood sugar, testosterone, talking about smoking, talking about lifestyle, and discussing both CT colography and calcium scores. So detoxifying men, just listed there, getting to a better place, knowing your numbers, cutting back on red meat, and I saw that binge responsibly on somebody's t-shirt the other day, which I thought encapsulated some things. And that's just a plug for the journal that comes out bi-monthly, and a lot of you hopefully will read. We're always looking for contributions to blogs and to the article itself. So I will hand on now to Dr. Carson, specially imported from North Carolina, to tell us a little bit more. Thank you, Cully.
Thanks, Roger, and thanks for the invitation to come talk about testosterone and cardiovascular disease. I'm obviously not a cardiologist, but I will give you my best urologic review of cardiovascular disease with regard to testosterone. It's a huge issue in the United States, as you'll see in a moment, because there's a class action suit, product liability suit about testosterone and cardiovascular disease generated by some questionable research. So these are my disclosures. Male hypogonadism, I think we need to define our terms, is a disorder associated with decreased testosterone and or sperm production, and has signs and symptoms. So it's not only the blood test, but it's also the signs and symptoms of androgen deficiency, and it's caused by testicular defects, which is defined as primary hypogonadism, or secondary hypogonadism, which is hypothalamic pituitary defects as well. And often it's combined, and it may be associated with but not caused by age, and it may be also caused by sickle cell disease or a variety of other conditions, but clearly it's a common problem. The public perception of testosterone, as Roger said, basically is the macho man, the aggressive, athletic, svelte man, but more often it's this man who has a decrease in testosterone with so-called menopause, where the testosterone is decreasing with age, and so are his symptoms increasing with that loss of testosterone. And this is what happened in the U.S. As soon as these questionable studies were published, not only we as physicians read these studies, but the lawyers read them as well. So as a result of that, there were 2,000 cases in the United States, legal cases against testosterone manufacturing companies for testosterone and associated cardiac disease. I was involved with some of that. Most of those patients had multiple risk factors, and really the testosterone was a minimal issue in their cases. So what do we know about testosterone deficiency and cardiac disease? Well, this is a very nice table that was put together in the Mayo Clinic proceedings about a year ago, and it shows some of the things that testosterone do to support the healthy male. It's a support of lean body mass, of bone density. There's an increase in adiposity, decrease in energy with testosterone deficiency, and a decrease in physical and sexual, obviously. Sexual function is what we think about, but there are many other things. Metabolically, you can see some of the changes that can occur as a result of testosterone deficiency, and there are associated conditions such as myocardial infarction, sepsis, and trauma that occur more commonly in men with decreased testosterone, as well as diabetes. Insulin sensitivity is dependent on testosterone levels. Renal failure, malignancy, hypertension, and hyperlipidemia all have an impact or are impacted by testosterone deficiency. And the final pathway is atherosclerosis, coronary artery disease, and cardiovascular events. So clearly, testosterone deficiency has a major impact, not only on the man and his sexual function, but his life in general. So why the controversy? Well, there are two trials that were published several years ago that suggested that testosterone replacement therapy may increase the risk of heart disease or stroke. They were poorly designed and conflicted with other studies that showed that testosterone replacement therapy, and indeed normal levels of endogenous testosterone, were associated with better men's health. So the FDA, the Food and Drug Administration in the United States, convened a panel, which I was present for, and decided that because of these two poorly done studies, that they would add to the package insert a warning, a black box warning for testosterone replacement therapy and cardiovascular disease, and that stimulated all of the product liability issues that we're facing now. So this is one of those studies, the Vegan study 2013, where they looked at over 8,000 men with testosterones of less than 300. The endpoints were all-cause mortality, MI, or stroke. These are men that were on testosterone replacement therapy, and they had an adjusted hazard ratio of 1.29, which showed some increase in risk for those patients getting testosterone replacement therapy. Contrast that with another study by Molly Shores out on the West Coast, and indeed the populations of the two studies were very similar. They were veterans. Over 1,000 patients with testosterones, this time of less than 250 nanograms per deciliter. In her study, all-cause mortality was an age-adjusted hazard ratio of 0.61, which is a decrease in hazard ratio, showing that there was a benefit in her group of patients for testosterone replacement therapy. Another study, Finkel and colleagues looked at 55,000 men, and this was a very poorly done study that really didn't look at the patients in detail. It just kind of looked at a population group. These are men that were 65 years or older, receiving testosterone replacement therapy with a relative hazard ratio of 2.2 in those men over 65, 2.9 in those men under 65 if they were taking testosterone replacement therapy. Contrast that with this study by Balogun, a very similar study again that used the same kind of technology and a population-based study, but what they showed was there was a reduced hazard ratio of cardiac events, cardiac death, and cardiac adverse events of testosterone replacement therapy. Unfortunately, the press, the lawyers, and the FDA got a hold of the first two studies, which demonstrated an increase in hazard. So I'm going to try to tell you and show you that testosterone was not only not harmful, but probably beneficial in normalizing in the average healthy man. So the problem with these studies were that the study populations were heterogeneous, intervention duration and study designs were all different. They had variable definitions of hypogonadism. They had variable ascertainments of cardiovascular outcomes. The treatment indications and indeed the treatment itself was unclear. In fact, there was none of these studies actually knew whether the patients took the medication or not. They knew that they got prescriptions, but none of them actually confirmed that either they'd taken the medication or that their testosterone had been normalized. So it really is kind of garbage in, garbage out. The study groups differed in baseline cardiovascular risk factors, so some of them had heart disease to begin with, some didn't. And really the findings were inconsistent across the studies, and really I think we would all agree if we review these studies that it's very difficult to draw any major conclusions. So let's start with endogenous testosterone, and this is a busy slide, but I'll just tell you a few things about it. Men with heart disease have significantly lower testosterone, free testosterone, and bioavailable testosterone. Low endogenous testosterone is associated with, in many studies, with cardiovascular disease mortality. The correlation of testosterone levels, erectile dysfunction, and conditions are associated with cardiovascular risk. Men with coronary heart disease under the age of 45 had total free testosterone significantly lower than controls. So basically, all of these things show that if a man has low endogenous testosterone, his risk of cardiovascular disease is significantly higher than a man with normal testosterone. And this basically is a meta-analysis by Araujo and colleagues published in 2011, which demonstrates that fact that if you look at all the studies that are available for this particular issue, that is endogenous testosterone, you can see that the overall risk is significantly higher for cardiovascular events. This is the Shore study demonstrating that patients with low testosterone were associated with increased mortality. She divided the testosterone levels into low, equivocal, and normal, and you can see that the patients with normal testosterone levels were more likely to survive, more likely to have a longer life than the patients with obvious low testosterone levels at a highly statistically significant rate. Androgen deprivation therapy and the risk of diabetes. So the patients that we place on androgen deprivation therapy for prostate cancer, again, these patients are artificially low in their testosterone, but their risk of cardiovascular disease, diabetes, myocardial infarction, stroke, and sudden cardiac death are substantially higher than normal, and the adjusted hazard ratios are quite significant. So endogenous or created low testosterones are a significant problem. This is again from the Mayo Clinic proceedings, suggesting that GnRH agonist therapy for prostate cancer is associated with atheromatous plaque instability. So that may be one of the causes, or it may be the primary cause of cardiovascular risk in those patients that we're treating with androgen deprivation for carcinoma of the prostate. What about treated versus untreated patients? Well, another study by Molly Shores, again, these are American veterans, and you can see the difference between those patients treated with testosterone replacement therapy and those patients not treated with testosterone replacement therapy, looking at their overall mortality with a highly statistically significant improvement in mortality at 48 months for those patients treated with testosterone replacement therapy in this particular study. Another meta-analysis that looked at testosterone replacement therapy and associated cardiovascular disease, major adverse cardiac events, which is MACE, or cardiac-associated deaths, again shows that those patients with low testosterone are more likely to be at risk for difficulties with cardiac events. The T trials, which are probably the best testosterone trials to date that are published in the literature, are double-blind, placebo-controlled trials of testosterone, treated with patients for a full year or more and followed for a variety of different endpoints. And one of the endpoints was cardiovascular, so the cardiovascular trial is what's on the left. And what they saw was that testosterone was associated with an increase in non-calcified coronary artery plaque volume, but not calcified coronary artery calcium scores. What does that mean? Well, the conclusion of the group was that they didn't know, and there's going to be more follow-up to look at that particular issue of a change in coronary artery plaques that were not calcified in those patients that took testosterone. But if you look on the right side and you look at placebo versus testosterone, you can see that in the cardiovascular events, specifically myocardial infarction, stroke, cardiovascular death, and the total cardiovascular or MACE events were equivalent in both the placebo and the testosterone group, showing that in this trial, which was an excellent trial, a really very good trial, there was no signal to cardiovascular adverse events in those patients with testosterone replacement therapy. This is the non-calcified coronary artery plaque that adds some concern to this discussion, but clearly we don't know the answer as to whether this is truly bad or not bad, and what the outcomes are based on these non-calcified coronary artery plaques and what their stability might be. So basically, this is an extremely busy slide that I'll just skip over in the interest of time. But the American Association of Clinical Endocrinologists suggests that patients that have low testosterone and symptoms and are not frail elderly should be considered for therapy for their low testosterone without significant concern for cardiovascular events in the otherwise healthy male with no significant cardiac history. So in conclusion, testosterone replacement therapy is well accepted in men with classical signs and symptoms of hypogonadism. Select chronic diseases and medications result in suppression of the HPG axis, especially those patients with opiates, those patients on therapy for prostate cancer, and may lead to significant problems with low testosterone and cardiovascular disease. Poorly defined mild reductions from chronic disease and aging should be risk-benefit associated. So if a patient has low testosterone and only mild symptoms or no symptoms, treatment is probably not appropriate. So with that, I will conclude, and thank you very much, and I'll now pass the baton to Dr. Mike Kirby.
Thank you, Callie. Now the next slide. So I'm talking about men, lifestyle, and the metabolic syndrome. These are my disclosures. I'm basically a tart. I work with anybody if it makes things better for my patients. So what is the metabolic syndrome? Well, it focuses on waist circumference. And this is the European definition, and this gives us a waist circumference of more than 94 centimeters for men and 80 centimeters for women, plus any two of the following: elevated triglycerides, a reduced HDL cholesterol, raised blood pressure, or a raised fasting plasma glucose. And in fact, having the metabolic syndrome is a very bad idea. If you look at morbidity and mortality in men without the metabolic syndrome, then I'll show you what happens when they develop the metabolic syndrome. You have increased coronary heart disease, infarctions, strokes, total mortality, and cardiovascular mortality all go up. It's a bad idea. Now, this study published in The Lancet gives us a clue about the importance of lifestyle in staying healthy. If you see here the leading causes of premature death and disability in England, as the percentage of disability-adjusted life years, dietary risk is at the top. Tobacco smoke, high body mass index, blood pressure, alcohol, fasting plasma glucose, cholesterol, renal function, and low physical activity, which takes us back to where Roger started from, doesn't it? Lifestyle is critically important. Unfortunately, when we look at the league of obesity, looking at the percentage of the population older than 15 with a BMI index greater than 30, we are third in the world. All our European partners are right down the bottom end, with France at 9%, Italy 9%. We're third. Sorry about that, Callie. You're top. Now this is important really, because in The Lancet they showed quite clearly that being overweight and obesity are linked to 10 common cancers and over 12,000 cases every year in the UK. The bottom line is that BMI was associated with 17 out of the 22 specific types of cancer examined. Now, visceral fat, we need to remember, is an active endocrine organ. Once you become fat in your abdomen, you become insulin resistant. So insulin levels go up. When people have pre-diabetes, they don't have low levels of insulin, they have high levels of insulin, and as a result of that, increased levels of IGF, which is a growth factor. Callie has already alluded to the fact that interleukin-6, TNF-alpha, and leptin switch off the pituitary and the production of luteinizing hormone, which reduces the testis production of testosterone. And aromatization of testosterone in abdominal fat increased levels of estrogen. It's an unhealthy thing to have, isn't it? Now we know that prostate growth is driven both by DHT and IGF. And these patients with metabolic syndrome have high levels of IGF. And in fact, insulin levels have been shown to be a positive independent predictor of prostate enlargement. If we look at the components of the metabolic syndrome, the more components you have, then the more likely you are to have a low testosterone. So it increased the risk of having testosterone deficiency by about tenfold if you have 4 or 5 components of the metabolic syndrome. Then a low testosterone, of course, then drives more metabolic syndrome. On the other hand, physical activity may reduce cancer risk, and this was published in the BMJ. There was a lower risk of 13 types of cancer, and this study included more than 1 million people. And although adjusting for BMI modestly reduced the association, there was a clear link between 10 cancers significantly associated with reduced physical activity level. Meta-analysis studies involving 43,000 men found that exercise intensity was related to the reduction of prostate enlargement, and the risk of BPH or lower urinary tract symptoms was significantly reduced for men engaging in light, moderate, and physical activity versus the sedentary group. But what about obesity and benign prostate enlargement? Meta-analysis of previous studies suggested that obesity was associated with a 28% increased risk of BPH. And the health professionals' follow-up study included 18,000 men without LUTS at baseline. Those with a higher total and abdominal obesity were more likely to develop LUTS or suffer from progressive LUTS. In the Rancho Bernardo cohort, a 4-fold increase in the risk of BPH was found in men with diabetes with the LDL cholesterol in the highest tertile. Conversely, HDL cholesterol was lower and LDL higher in subjects with symptomatic BPH versus controls, and there we have the metabolic syndrome. A low HDL cholesterol is important. It's a negative independent predictor of prostate enlargement. What about cholesterol? In subjects with BPH, the addition of statin therapy has been shown to increase prostate volume reduction by 15-fold. So what is this relationship between lower urinary tract symptoms and metabolic syndrome? Because we've demonstrated there are interconnected physiological, biochemical, clinical, and metabolic factors directly increase the risk of cardiovascular disease, type 2 diabetes, and all-cause mortality. And I've already defined what the metabolic syndrome actually is. But the presence of metabolic syndrome and the number of metabolic syndrome components is related to LUTS and BPH severity. And men with BPH are more likely to have the metabolic syndrome than men without BPH. This is a study that we published in the BJUI, showing quite clearly, this was a database study taken from primary care general practices, that men with BPH are more likely to have the metabolic syndrome, and each component of the metabolic syndrome compared to their matched controls without BPH. And that was true for both lifetime and the current definition of metabolic syndrome. Now we know LUTS and ED are often coexisting. And in fact, in men who are seeking treatment, about 78% of them will have both conditions. And the reason for that is there are pathophysiological pathways that lead to both LUTS and ED in men, with preclinical evidence the metabolic syndrome is associated with insulin resistance, which activates the sympathetic nervous system, and there's an increase in prostate smooth muscle tone. Cully's told you about the hormone changes we see with increased estradiol and a lower testosterone. The risk factors cause pelvic atherosclerosis. There's bladder and prostate ischemia and ischemia of the corpora cavernosum. and inflammation by the cytokine release from the abdominal fat. All of this leads to ED, LUTS, BPH, and BPE. So what do you need to consider if your patient is presenting with symptoms of ED or BPH? If they have one, we should be asking about the other. We should be asking about sexual and urinary health. And think about doing the HbA1c. Could this man have prediabetes, hyperlipidemia, raised blood pressure? What is the waist circumference? Has he a raised PSA? And what is the testosterone level? Lifestyle can improve both ED and BPH. I've already demonstrated that it should be a first-line intervention and has significant benefits leading to a reduced risk of cardiovascular disease and diabetes, improved erectile function, improved lower urinary tract symptoms, and testosterone levels. We need to encourage our patients to alter their weight, lose weight, increase physical activity, stop smoking, be moderate with alcohol, and manage stress. So as physicians and surgeons, we need to monitor and manage these reversible risk factors that I demonstrated early on in the presentation. We should not miss the opportunity to emphasize the importance of a healthy diet, physical activity, and smoking cessation. And sexual counseling, of course. But PDE5 inhibitors have an important part to play, both in managing the LUTS and the ED. We need to deliver this message at every contact in a sincere way, which is non-judgmental. We need to move our patients from contemplation to action, because on the whole, they know what they should be doing. Mark Twain said, "You can't throw a habit out of the window. You have to coax it downstairs one step at a time," and I'm not saying it's easy. There are two, I think, very important studies about PDE5 inhibitors, and I think we miss a trick if we don't use them in our patients with ED and lower urinary tract symptoms. The study on the left we published in Heart. It was a GP database study where we looked at men with diabetes and compared those who'd ever taken a PDE5 inhibitor with those who'd never had. Over 7.5 years, there was a 31% less risk of all-cause mortality in those men who were being treated with PDE5 inhibitors. A couple of months later, in the same journal, a Swedish research group had done something very similar, but they did it with patients who had cardiac disease and had a heart attack. They asked the same question: have you ever taken a PDE5 inhibitor? Amazingly, they found exactly the same benefit from taking these drugs, a 38% less risk of all-cause mortality over a mean of 3.3 years in men taking a PDE5 inhibitor. This was not the case in men using injection therapy to manage their ED. So keep this in your consulting rooms. When you see these men, it gives you an opportunity to talk about diet, but also exercise. You'll see at the bottom, these men should be exercising twice a day. 20 minutes of exercise increases your insulin sensitivity for 15 hours. It's important. Lots of fresh fruit, vegetables, salads, and fish. Keep away from too much in the way of dairy products, red meat, and sweets. It's a simple message, can be delivered very quickly, and I get them to stick this on the front of their fridge. When you open your fridge, this is what it should look like. It saves lives. This is a Spanish study, and they see here we compare a control diet, which is a typical low-fat diet, with a Mediterranean diet. You reduce the risk of a myocardial infarction by about 30%, and you reduce mortality by about 25% over a 5-year period. And those curves seem to split quite early. Mediterranean diet versus low-fat diet. At the end of the day, if the patient won't listen to what you suggest, I suggest you try this. What fits your busy schedule better? Exercising for an hour a day or being dead 24 hours of the day? The bottom line is we need a more precise patient profile. Think, when we see our patients, what is actually going on within them in terms of metabolic syndrome. At the end of the day, we all need a true friend, don't we? The only person I would do this for is my brother, and I have. it may not be a drug. And there, Mr. Chairman, I rest my case, and I'd like to introduce the next speaker, Dr. Rupal, please.
Good afternoon. Thank you very much for the invitation. So I'm going to now turn the story a little bit towards lung cancer. So just to really highlight why is lung cancer important and why so particularly in men? Well, it's the second most common cancer and it's the biggest cause of cancer mortality in men in the UK. And 97 people, and mostly this is more men than women, die every single day from lung cancer. Lung cancer survival at 1 year is pretty poor at 30%, and it falls dramatically down to 8% and 4% at 5 and 10 years. So why is this? So people who are diagnosed with stage 3 or stage 4 lung cancer typically are inoperable, and therefore options for treatment are limited. This is rapidly improving just over the last year. We've got some really fantastic new treatments available, but really the number of people qualifying for these treatments is still low. And the main thing that we can do at the moment is to improve our rates of early detection. And certainly at the moment, about 70% of patients are being diagnosed at stages 3 and 4 and inoperable, and therefore outcomes are still very poor. So what about screening? It's not a novel idea. Why have we not thought about this before? Lots of trials were done, starting as early as sort of the 70s, looking at sputum cytology and chest X-ray, but none found any mortality benefit. Thanks to advances in CT processing with a dramatic reduction in radiation dose, this was a new era for lung cancer screening, and that low-dose CT came into play. And actually, today we have ultra-low-dose CT, which is a fraction. It's about half a millisievert in terms of each scan. The sensitivity for picking up lung cancers is much higher, and we can pick up really small, early-stage lesions. Of course, with this comes the problem of indeterminate pulmonary nodules, and that's a separate issue that we have to deal with, prepare for, so that we can reduce harms from that as well. So everything really changed for lung cancer screening in 2011, and this big study, which was in just over 50,000 participants, and what they did is they screened, the intervention arm had low-dose CT every year for 3 years, and the control arm had a chest X-ray every year for 3 years. And it was just for 3 years, and they followed patients up for a further 7 years. And the trial at that point was stopped because they had reported an outstanding reduction in lung cancer-specific mortality and even in all-cause mortality, something that we haven't really seen in other screening modalities. And a study in the UK lung cancer screening study, found that this is an extremely cost-effective intervention, much, much more so perhaps even than breast cancer screening, with a cost per QALY of about 8,000 to 9,000, so a third of what's really required by NICE. So where are we with lung cancer screening? Well, in the US, they're doing it. They're doing it for high-risk smokers, so that's neglected to mention, but that's who were included in the National Lung Screening Trial. And typically they recommend it for people aged 55 to 80, although Medicare and Medicaid are now funding it for those aged 55 to 77. And they crucially have to have quite a high smoking exposure. Where are we in the UK? Well, as I mentioned, there was the UK lung cancer screening study, which took place across 2 sites, and there were several small-scale pilots since then, one of which I've been working on down in London. A more new study has been started in Leeds, which is aiming to scan about 7,000 people, and now £70 million have been invested into the NHS England pilots across these sites, meant to be taking place in areas of unmet need where lung cancer prevalence is particularly high. But the National Screening Committee, at the moment, as you can see, this page looks like it should have been updated a couple of years ago, and we're still waiting on it. And this is mainly because the National Lung Screening Trial that I presented at the beginning of the presentation was a big study in the US, and it was a very well-conducted study, but it was a single randomized control study to date that has been shown to prove a mortality benefit. So the Nelson study is a Dutch-Belgian study, a much smaller study, much less powered to detect a mortality benefit, and up until very recently we were waiting for the results. We're still waiting for the full manuscript, but there is a significant improvement in lung cancer specific mortality that has also been corroborated in this study, and I'll come on to that. But the National Screening Committee in the UK, as we understand it, are still waiting for the full manuscript to be published, and hopefully we can await a decision on it, and maybe we'll be seeing it more widely in the UK. Well, are there lots of different challenges? So I've just touched on the political issues with NSC buy-in, and obviously these things cost money. It's cost effective, but obviously in this particular climate within the NHS, funding is obviously a bit of an issue that needs to be overcome. There are other issues. We've been recently embarking on a larger project, and infrastructure is crucial. The IT, the service demands, the number of lung cancer resections, etc., that are going to be necessary, as well as making sure that QA and governance are robust, and also software such as volumetry is available widely. And then there are research topics that we need to probably understand a bit better. And again, all of these pilot studies that are going on are helping us to understand much more about how we can improve these things. So integrating smoking cessation is really, really crucial. And we heard a little bit about that, how to manage incidental findings and these pulmonary nodules, and improving equitable uptake. Sorry, I can't speak. Also about balancing harms, so overdiagnosis and radiation, probably not too much of an issue overall, but still things to be considered. It's important that our patients have the options to make an informed, and the tools to make an informed decision, and obviously trying to reduce the benefits and harms by optimizing the screening intervals. So just to bring it back to men a little bit more, we did some qualitative work looking at the different screening programs and what people thought about them, and we were then obviously asking more about lung cancer screening. But interestingly, one male participant said men ignore things more than women. We've heard that earlier today as well. And then other than bowel screening, that's all that men get, isn't it really? So, you know, at the moment, there are breast and cervical cancer screening options available for women, but really not a great deal for men. So lung cancer screening is an amazing opportunity for that in terms of improving men's health. So just to bring it back to equitable uptake, so we know that those who are highest risk for lung cancer, so those who are from more socioeconomically deprived communities and those who are typically current smokers, are least likely to attend screening, and particularly sort of lung cancer screening. And this is Dr. Sami Quaife, who's a psychologist that we've been working with. So we did something called the Lung Screen Uptake Trial, where we tested out, so the picture in the middle is sort of a screen grab from the invitation leaflet, which is aimed to try and improve uptake to lung cancer screening by reducing scary messages like about cancer and about smoking, reducing stigma, and also to be more palatable and less frightening, compared with a really well-written leaflet, which is more in line with other NHS literature. And we're still analysing these results, but through doing this, we've been able to screen about 770 people and have brought about a massive stage shift in lung cancer. And this is similar to results that we've been seeing around the country with other pilots. So as you can see, the dark blue bars are our much more increased stage 1 diagnosis compared with the national averages. And our resection rates have increased from about 18.4% nationally to 75%. And even with small cell, we had 100%, which is small cell lung cancer is very unusual to be detected at an early stage, and we've managed to give everybody chemotherapy. So some really promising results from this. And then this is Professor Sam Janes, who's my main boss, and he's been leading the sort of spin-off study to this, which is an immense 25,000 participants. It's going to be one of the largest lung cancer screening studies worldwide. And it's now underway. We've screened, I think, almost up to the first 1,000. And again, we're going to be looking at lots of different outcomes and looking at biomarkers in terms of how we can try and improve lung cancer diagnosis. So this is the Nelson study, and I was talking about the abstract that was presented at the World Lung Cancer Congress in 2018. And you can see here, quite interestingly, that there's a significant relative reduction in men. Interestingly, in this study, about 84% of the participants were men. So you can see that the confidence intervals here for the relative reduction in women is actually quite wide. and that's mainly because the sample size was quite small. But here you see a signal that perhaps women might be benefiting from lung cancer screening more than men, which is quite an odd finding, and I don't think we fully understand the reasons why. But interestingly, looking at NLST, the American study I presented at the beginning, a similar signal was seen here. So do take the figures here in terms of the cost per QALY with a pinch of salt. This is American figures where things are a little bit more expensive, but you can see that women were 3 times more cost effective to screen than men. And again, we're not really sure why, whether this is due to tumor biology, whether it's to do with increased life expectancy, lots of unmeasured factors such as diet and exercise and all these other things. And it's something that I think clearly needs to be looked into in more detail, but is quite an interesting finding. And I wonder whether part of it is related to bringing it back to the earlier talks, but cardiovascular disease, for example. So we know that ischemic heart disease and stroke and also other respiratory diseases are within the top 3 causes of death worldwide. And we know from the NLST data that in the screened arm, in the low-dose CT arm, where they reduced the deaths from lung cancer, cardiovascular disease became the most common cause of death. And this isn't surprising because obviously smoking and age are the risk factors for all of these conditions together. And we know that men are much more likely to have coronary heart disease and more likely to have stroke than women. So perhaps this is something that we can exploit further with lung cancer screening. And we heard earlier about coronary calcium scores, and I didn't include a slide on this just for the interest of time, but low-dose CT scans in lung cancer screening context can also pick up coronary calcium and can be a real motivator perhaps when we feed these results back to patients to tell them, well, look, you've got calcium on your scan, and actually this is another reason to stop smoking or another reason to address your high blood pressure and cholesterol and so on. And in fact, within our lung screen uptake trial cohort, we found that 98% of participants, before they even had their scan, already met the Q risk, the criteria for having statins as primary prevention, and yet only half were actually taking them. So there is here a huge opportunity through lung cancer screening to address these other comorbidities that affect the health of men and women. So just to conclude, lung cancer is an important cause of mortality, and there really is an urgent need to improve outcomes. We've got 2 now big studies that have provided clear evidence, and actually a third one from Europe that I didn't talk about as well, from Italy, that really confirm that it does work to reduce lung cancer death. There's lots of important and exciting projects underway around the UK, and will help us to really address all the other issues that are outstanding, and hopefully we'll be able to have a national rollout at some time in the future. Women might stand to gain more benefit from lung cancer screening, but perhaps by addressing some of the other issues, we can make a greater impact on men's health also. Thank you very much for listening, and thank you also to my mentors and supervisors.
Well, great. That was all our speakers kept brilliantly to time, so we've got a few minutes for discussion. So I'd really like some feedback from the audience about whether you think the message that urologists should be men's health doctors in the same way that gynecologists are women's health doctors. And if you think about the different emphasis on women's health, where every GP practice will have a women's health specialist component, compared with really the lack of interest in men's health, it's a political issue as well as a medical issue. And I guess thinking about D words from my slide about the Ds, the D word for men's health is really deprivation, because nearly all these problems, smoking, alcohol, risk-taking, HIV, etc., is very strongly correlated with deprivation and more common in deprived areas. So, any comments from the audience? We have some microphones. Prokar Dasgupta, prostate surgeon extraordinaire, editor of the BJUI, and nice person. Prokar.
Talking about nice, Roger, of course a nice person, but the NICE guidelines on prostate cancer 2019, just published in the BJUI, make no mention of screening. The EAU, of course, does not recommend screening. How can a urologist avoid the prostate cancer issue and talk to men about lung cancer bowel cancer and heart disease instead?
Let's ask Cully to answer that. It's a bit of a tricky question. May as well pass the buck.
That's a tough one because I know nothing about NICE, so I know nothing. Well, in the U.S., it's changed. So the guidelines in the U.S. were initially that no men should get PSA, and if there was a decision to do a PSA on men, it should be discussed. That's kind of paraphrasing the guidelines, but they've since changed that, and now the guidelines are that men over the age of 50 should get PSAs, assuming that they are willing to do that, and if they have high risk factors for prostate cancer, a family member, et cetera, African American, then even more emphasis is placed on doing PSA. So the pendulum has swung in the U.S. to some extent. It hasn't come back to widespread screening yet, but it's come back to at least, I think, a reasonable way of approaching PSA in prostate cancer.
Prokar, the National Screening Committee are doing an evidence review on prostate cancer screening. And the Prostate Cancer Risk Management Program says quite clearly that any man who wants to know his PSA is entitled to know it. Again, it's one of the things where perhaps men need to know their numbers. I think it's really interesting that perhaps it's more important the younger men, because you know the PSA between 40 and 50, but if your PSA is over 1 when you're 40, then you have a 19-fold increase in the risk of prostate cancer in future years. And it may be that doing it before people get BPH gives us a much more useful figure for predicting future prostate cancer, and also advising people how often they should have their PSA done. Because if you've got a PSA less than 0.6 when you're 40 to 50, you probably don't need to have a PSA done for many years ahead.
Let's ask Mamta a question, because she's come all the way up from UCL to talk to us about lung cancer. Mamta, I guess from urologist's point of view, is what should we say to our patients who smoke? How do we persuade them to quit?
I think it's a real challenge, isn't it? I think in the respiratory clinic we find it a real challenge, and these are people with direct symptoms often from their smoking, and yet often tobacco dependence is the kind of thing that makes it very difficult for people to actually want to stop. But I think there's some useful guidance, and there's in fact a very brief advice training module that people can do very easily, which talks about asking, advising, and arranging follow-up in terms of smoking cessation, letting them know that behavioural support and drug support really work well together. I think varenicline is really, really useful as well. And ultimately, I think letting them know that quitting is a journey. Many people quit several times before they're successful. And I think just the more health professionals that keep pushing that message, eventually they will at least begin to get through, hopefully.
Should we tell them to vape instead of smoke?
I think the current advice on that is probably yes, in terms of harm reduction. We obviously don't know all the harms associated with vaping, but we think it's the lesser of the two evils. And I think it is a really useful way for many people to stop.
Well, in the audience, we've got the one and only professor of men's health in the UK. You're a very rare species, endangered species, actually. Professor Alan White, any thoughts, comments, questions?
Yeah, very impressive conversation. But what was going through my mind as one of the baby boomers, 59 I was born, and my chance of growing up to be old and then very old is a new challenge for you. How do you see 1 in 4 of us being over 65 by 2040? How do you see the 90-year-olds, the 100-year-olds that you're going to come through your clinics as new challenges to you?
Well, maybe Cully, Mike, any thoughts? I mean, we are seeing, is it centenarians, people who are older than 100 quite often these days?
Well, the secret is staying fit throughout your life, really. We know, certainly from the testosterone studies, that 75% of men retain normal testosterone levels right through their lifetime, as long as they don't collect comorbidities, and particularly cardiovascular risk factors, metabolic syndrome. So I think the key is to have a healthy diet and exercise right throughout your life. And if you take one message away from me today, is you need to get out there and do some exercise twice a day. Make sure you've got your step counters, do your 10,000 steps, and really good evidence that staying physically active and eating a healthy Mediterranean-style diet will reduce a lot of the comorbidities that we're trying to deal with in people in their 80s and 90s.
There's a great jogging track down by the Clyde, actually, so we'd like to see everybody in the audience with their running clothes on tomorrow. We've got 6 seconds before we finish, so I'm going to leave you the last word: binge responsibly. That's my message, personal message to urologists worldwide. Thank you, everybody.
Much looking forward to hearing from both John and Bez, one half of the Atlantic Seaman team. But before we do, this is the point at which we award the Urology Foundation Medal for the Best Research Proposal 2019. And the winner this year not only came top in the peer review process against an extremely strong field of candidates, it must be said, but also scored extremely highly in our 3-minute pitch process, which in itself is a very high-pressure event held at the Royal Society of Medicine in front of an audience of both experts and lay people as well. And so for her research into investigating renal cancer metabolism using novel surgical methods, I'd like to invite Sissy Yong from Cambridge University up onto the stage to come and receive her medal from John and Andy, please. Thank you. Thanks very much. And now John Davis and Andy Berry, Bez, and it's not my words, so I hope they won't take offence, but they do describe themselves as just a couple of ordinary middle-aged blokes. And so we're now going to find out how these two seemingly ordinary men have done something very extraordinary and rode an ocean. Over to you.
So, good afternoon, ladies and gentlemen. Welcome to the Urology Foundation lecture, When the Rowing Gets Tough. So my name's John, and this is my rowing partner, Bez. Hello. And we make up one half of a ocean rowing team called the Atlantic Seamen. And this last December, we set off on what was a challenge of a lifetime to row 3,000 miles unsupported all the way across the Atlantic Ocean. The main aim of this adventure was primarily to reignite some passion for adventure in 4 sedentary middle-aged men, but also to raise lots of money for the Urology Foundation and awareness of urology disease in general. So a little about the challenge itself. The Talisker Whisky Atlantic Challenge is described as the world's toughest row, and it's probably one of the most arduous, challenging endurance events on the planet. The event begins in the small island of La Gomera, which is one of the islands of the Canaries, and in fact the same island from which Christopher Columbus set off all those years ago on his own Atlantic voyage. And then what you need to do is row 3,000 miles all the way across from the east side of the Atlantic to the finish line in English Harbour in Antigua. This year, 28 teams took part in the event, and you either row as a soloist, a pair, a 4-man team, or even a 5-man team. And we were a 4-man team. So what that meant was that we had to row for 2 hours on, 2 hours off in pairs, all the way from the start of the race to the finish, which took us 43 days in total. Whilst all the teams set off in a fanfare of glory from La Gomera from the start line in the same day with press, photographers and boats everywhere, about 7 hours after you leave shore, in fact, that's probably the last time you're going to see any of these ocean rowing boats for the entirety of the crossing. The actual distance between the first boat in the fleet and the last boat can be anywhere up to about 1,000 miles. So you really are remote out there on the ocean. And the Talisker Whisky organisers, the chaps who organise the race, are absolute pains to let you know that if you're in trouble out at sea in the middle of the ocean, then physical rescue is probably 3 or 4 days away at best. But to give you a better idea, what we're going to do now is show you the race summary video from Talisker. So if you sit back and relax and enjoy.
Well, this is it.
Bring on the adventure.
The rowers come from all walks of life. What they have in common is determination.
We're going to go out hard and see what happens.
Jesus, so much emotion. Can't wait to go home.
And we're off. The Atlantic, that's where we're going. On our way to Antigua.
The sky is blue, the sun is shining, and the waves are almost agreeing with us.
I've never seen it so calm.
So, thank you. So, who are the Atlantic Seamen and how did all this come to be? Well, personally, I dreamt about crossing an ocean for about 10 years. I read about the adventures of Che Blythe and John Ridgway, who were the original pioneers of ocean rowing, who in 1968 set off in a very much smaller version of the boat that we rowed in and set off across the Atlantic Ocean. And so looking back on their adventures, I dreamt of this challenge for a long, long time. But unfortunately, because of work commitments and family life, the reality of planning and undertaking something like this was an absolute impossibility. Until I finished my GP training, obviously at quite a late stage, and saw the opportunity to take a sabbatical before taking up a permanent GP partnership. So my wife had actually forbidden me to take on the adventure as a soloist, so I needed to set about finding 3 more people who would join me on the journey. So I was looking back at some of my ex-army colleagues and some friends of mine who had done previous long-distance endurance events, and unfortunately the answer was generally, don't be so crazy, definitely not for me, or I'm not sitting on a boat with you for 2 months, John. So rather despondent, I phoned up my friend Andrew, who was lurking around the corner, and I said, look, Bez, come for a pint with me because I'm really fed up. We sat down at the pub and I said, Bez, nobody wants to do this amazing challenge with me. And then suddenly Bez piped up, I'll do it. And after much mirth and laughter, I looked at him and realized he was actually very serious. But this turned out to be an absolute godsend because Bez's amazing organizational skills and dogged determination have proved to be absolutely invaluable in the 2 years it's taken to plan our adventure. We also fortunately managed to recruit Andy and Alex, a friend of mine from home who's a sailing instructor, and his friend as well, who is an absolutely phenomenal engineer, so he came in very handy. So why the Urology Foundation? Well, as a GP, I obviously see firsthand the devastating effect of urology disease. And also at the start of the planning phase of the row itself, my own grandfather sadly passed away from renal and prostate cancer. So when Ben Eddy suggested the Urology Foundation as the charity of choice, it seemed like a really obvious choice to us. The Urology Foundation are leading the fight against urology disease, and in fact, they are the only charity in the UK and Ireland who tackle all urology disease. I'm going to hand you over to Bez, who's going to take you in the planning phase.
Good afternoon. I'm just going to talk about planning. It took 2 years from that silly conversation in the pub with John to us basically finishing the race. You know, the race, it's organised by a company called Atlantic Campaigns, and it's called the Talisker Whisky Challenge. I mean, the 2 words in each organisation basically sum up what it was about. It was definitely a challenge, and it was definitely a campaign. You know, we were trying to raise awareness, raise funds, raise sponsorship, so we could do the race. You know, we sent out thousands of documents. We chased it up with emails. We were trying to train. You know, at some stage we were doing 3-4 hours training a day on ergos and whatever else. So it was really difficult. And it was more like having a second full-time job, as well as trying to, you know, couple with what we normally do. You know, we both got young families, and it was really hard. It was more or less impossible sometimes day to day. And also, probably 6 months before the start of the race, we lost 2 members of our crew, which was really stressful. And also, we didn't have the funds. We had a month to find our race funds, so it was all really difficult. And then things started changing. We were really lucky. We found 2 new members of staff, 2 new members of crew, Andy and Alex, and we got a really substantial amount of money from Intuitive. So thank you very much to them. You know, for me, I believe the journey to the start of the race was more difficult than the journey itself. You know, as I say, we were trying to raise awareness and funds, and it was really difficult. We had a heck of a lot of help from Tough trying to do that, and they were brilliant. You know, we secured some really good sort of media coverage and press coverage, which was great. We're also on Channel 5, both in around Britain, which was lovely. And we got some really good coverage and support, help with Ben Chalicum from Stephen Fry and Ben Eddy. You know, we had Sir Ranulph Fiennes give us a really good endorsement, and we did really well. We're also on Radio Cornwall every Wednesday morning, even when we were doing the race, every Wednesday morning. John would get to stop rowing for half an hour, I had to carry on, and he did an interview on Radio Cornwall, so that was great. The big thing is, we talk about teamwork, and I understand all you have incredibly stressful jobs, and teamwork is paramount, and teamwork is sort of key. You know, we work really well together. As I say, that unity and strength got us through at times. We started really late as the four that rowed across the Atlantic. You know, as I say, in July, it was really stressful. But we worked really well as a team. I can give you two examples. On the, you know, packing the boat, as you can see all the kit. There was a heck of a lot of stuff to get on the boat, a heck of a lot of stuff to organise. We packed it, we did it really well. In fact, the race organiser said that we were the most organised team, which was great. Another really sort of stressful thing happened. On day 5, we had a problem with our steering. It's called auto helm. And basically, the solar panels weren't charging the battery, so it stopped working. And it was like 3 o'clock in the morning. There was massive seas, sort of 5-6 metre high seas. And the first thing that we had to do was stop the boat capsizing, and then we just had to try and work out what the problem was. And as a team, I think we did really well. It took us 5 days to work out that problem, but there we go. You know, the race start was phenomenal. You saw it in the video. It was a really exciting thing to be part of. And the other thing being is, John and I were absolutely ready to start. You know, we'd been planning it for 2 years. It had controlled our whole lives. You know, the race start was amazing. So you had lots of people, you had chatter, you had the music, you had flags, you had klaxons. And then we all set off 10 minutes apart to, again, massive cheers and loud sort of air horns. It was brilliant. I mean, the first 24 hours was just a complete blur, really. But it's also a realisation that you know, you're doing it. You can't climb off. You can't turn back. There is no help. It's just you, your crew in the boat, which was amazing, actually. And we're really pleased to start. You know, we talk about passion and it being an enormously powerful force. You know, for me, being in a boat 1,000 miles from land was, you know, with no point of reference, it's quite scary. You can't see the bottom. You can't see any land. You just got sky. It was really scary. And you know, having that drive and that goal and that passion, it sort of puts things into perspective. You know, for me, I was 50 this year, which was so I was 49 on that photograph. But I was 50 this year, and I wanted some sort of epiphany on the row. And I think what I got was that passion. I really loved my family. I was really lucky. You know, the row is, you know, for the first 5 days, we were absolutely shattered. We had no idea how difficult it would be. And then you realise, you just think, gosh, you know, we're only 10% through the challenge. You know, if we can't get the auto helm working, it could be a heck of a lot longer. So we've got another 40 days to do. So you were absolutely shattered. And we put there eat, sleep, row, repeat, and that's exactly what it was. You know, to eat, you had to boil the water, you had to rehydrate your food, you had to try and take on 6,000 calories a day, and you had to try and drink 10 litres of water. So it's really difficult. I mean, sleep, you know, you try and get as much as you possibly could, but you've also got to do all your chores. You've got to do your personal hygiene. You've got to make that water. You've got to tend to your wounds. You've got to fix your boat. You've got to clean the boat. So you were only probably getting maybe an hour's sleep within those 2 hours. So it was really difficult at times. You were shattered. And then you've got to row. And there was many a time I'd be sort of sat in my cabin going, do I have to get on those oars again? And you did, and I've got to say it was great. You know, I sort of rowed with John every time. And you didn't want to get on the oars, but the minute you're on, you'd just be chatting. You'd have a little, you know, have a little sing-song. You might just be quiet, you know, we'd play music. So it was wonderful. I mean, I remember one night, which was particularly amazing. It was incredibly calm. You know, the sky was full of stars. We saw loads of shooting stars, which was amazing. And the ocean was absolutely flat calm. It was slate grey. And every time we sort of tapped the oars, we got all the phosphorescence off the back of the oars, and it was amazing. We had a pod of dolphins down our port side, and we were listening to Graceland, so we were singing and sort of having a nice time. But as I say, you know, that eat, sleep, row, repeat, it's that routine and that discipline that sort of gave us focus and got us through at times.
So hopefully Bez has described some of the high points of the row itself, and we really did have some life-affirming highs. But unfortunately, as you might expect, we did have a tipping point, and we did have some desperately sort of dark low points on the boat. Living for 43 days on a 23-foot boat with 4 smelly middle-aged men who are on the whole naked is really quite a tough thing to do. And really interesting, one of the things that people have asked most often since we've come back from the row, which I found quite fascinating, is did you get on? So people don't come up to us and say, you know, tell us about the big waves, tell us about the time you swam with a whale, or whatever it might be, the lovely night skies, whatever it is. Everybody wants to know, it's obviously human nature, everybody wants to know, did we fall out and did we argue? So I developed a stock answer to that question. And I say to people, well, imagine if you were on a little boat with your husband, partner, wife, and you rowed away from shore into the middle of the ocean. How many days do you think it would take before you started arguing? And I think it's a bit of a reality check for people because, yes, we did argue, but I'd like to say that it wasn't very often. And, you know, those arguments generally were bore out from extreme fatigue. So I apologise slightly for this next slide, but it basically is a collection of photos that gives you an example of some of the tough times we had on the boat. So that's, in the top right-hand corner, that's somebody's bottom. And that's what a bottom looks like just before you develop proper saltwater sores. And as you can imagine, once they develop, there's literally nothing you can do apart from just lather on Sudocrem tub after tub. So that was hard work. In the middle photo at the top there, you can see Bez, and he's steering the boat by hand steering, so there's some little pulleys either side of the boat. And that's because, which you can't really tell in that photo, the magnitude of the waves. We had 2 or 3 story high waves, and that boat was firing down the face of those waves at about 11 knots. So any mistake in the steering, that boat's going to just flip over. And then you can see the food in the top left-hand corner there, which was just diabolically boring. But as you can expect, you know, we briefly mentioned earlier about losing power. I just wanted to reiterate how awful that was, that sensation of thinking we might be about to lose power. About 800 miles from land we were, and we could see our battery chargers going down and down and down. So just to explain, without power, we can't steer the boat automatically. We can't make our water without hand pumping. There's no electronic navigation equipment, and there's no way of communicating with people. So that power loss would have meant that our journey across the ocean, instead of taking 40 days, could have potentially taken 80 days. And we knew that, and that was really, really devastating until finally we found this faulty switch and managed to get the problem fixed. But of course, I think you'd also expect us to talk about the weather. And the weather was just amazing. In the bottom right-hand corner, you can see a squall. And when we came towards Antigua, these squalls hit us so feverishly, so powerfully, that it was impossible not to be scared. You could be rowing in flat, calm water, and 1 minute later, you're in the middle of a howling storm. I remember one particular night when me and Bez were rowing, when the waves were so big, and it was hammering down so hard, with 40-mile-an-hour wind on our stern, and we just had to keep rowing. If we'd opened the hatches to let out our teammates onto their rowing shift, we simply would have swamped the boats and potentially capsized or sunk the boat. So we just had to make the decision that we were going to row for 4 hours non-stop, and it was pretty horrific. But the main challenge for us on our row, as you saw from the original video, was we were becalmed for a lot of the time. The Atlantic trade winds, which are supposed to blow you from east to west, just didn't help us at all. We had wind in the wrong direction, we had adverse Atlantic currents, and one day we rowed for 12 hours and we made 1 mile. So what have we learned from all this? I think we would all agree that you know, one of the most important aspects of working in a difficult circumstance, in a team environment, either on something like this or indeed in real life, is the importance of humility. But also we learned the importance of being able to say sorry. So during those very dark times when we really did fall out, and somebody was having a really tough day, the characteristic of humility was, and understanding was really, really important. And we also learned the importance of a proper, heartfelt apology. We also learned respect for each other, and the fact that sometimes people just need to be in their own thoughts. Privacy is really important, which sounds strange because on the ocean rowing boat, there's nowhere to go. So the only privacy you have is in your own head. So the only chance you can get away from people is just by delving into your own thoughts. And we had to learn to understand that because you expect people to be talking all the time. And people weren't being morose, they weren't being miserable, but they just needed a bit of space. And so we had to learn to respect that. But in the end, through hellish adversity, discomfort, and extreme fatigue, this only served to make our dream a more powerful reality. A phenomenal 2 years of hard work, 43 days on the ocean, and here we are at the finish line in Antigua, only a few oar strokes away from our family and friends, just around the corner in Nelson's Dockyard. Simply one of the most phenomenal, life-changing moments for any of us. It was absolutely amazing. For those 2 years, anything could have gone wrong to make the dream crash and burn, and this was the point where we realised we'd done it. I think there's a little video. Okay, the long-awaited day we've always dreamed of. Another little shot of the Absar team following the Atlantic Seaman into Antigua after their crossing of the Atlantic Ocean, taking 43 days. There they are, and here are the guys who've done it all. Hey, right. Woo! Yep. There you are, guys, Atlantic Seamen's legends in their own lifetime.
I've got to say, 43 days, it was 8 hours and 4 minutes it took us. I mean, for me, looking at, spending 15 hours looking at sort of naked men, looking at willies and testicles, I couldn't do a job like that. Coming into Antigua was a phenomenal experience. We had lots of boats out there, all cheering us on, and it was a phenomenal feeling. We rode into Nelson's Dockyard with all the super yachts, pipping their horns and shouting and cheering us on. Seeing our families up on Shirley Heights was an amazing experience. Getting off the boat after 43 days, we couldn't stand. Our legs just didn't work at all. So we got off the boat to rapturous applause, wobbly legs, and we all got to hug our families, and that was a phenomenal experience.
So, what are our thoughts now we've finished it? Now the row is a few months behind us. Was it worth it? I think the whole team would definitely agree that it was definitely worth it. It really did turn out to be the adventure of a lifetime. It was absolutely phenomenal. But I agree with Bez. Looking back, the hardest part by far was the 2 years of planning, the hard work, the stress, the worry, and we definitely couldn't have done any of that without the support of our family and friends. As you can see, we're not superheroes, neither are super athletes, but hopefully what we've proved to each other and maybe other people is that, dreams and adventures are definitely within reach for anybody. I think you just have to pick the challenge, be prepared for the hard work, push through any adversity, and keep your eye on the end game. I would finally like to say a massive thank you to the Urology Foundation again, in particular to the fantastic Ciara, Louise and Serena, and of course our good friend Ben Eddy. Without all of these guys, the adventure wouldn't have come true at all. And of course, an enormous thanks to all our sponsors, and of particular relevance today would be Intuitive, Surgical, Ashford Hospital and CJ Medical. Ladies and gentlemen, thank you very much.
Thank you. A huge thank you to John and Bez. And if you'd like to know more about their adventure, they are still around for the rest of the afternoon. And so you can come and speak to them on the Tough Stand, number 322. Thanks very much, everybody.
Rowing as an undergraduate. I spent actually probably more time on the river than I did in the hospital, but that's pretty inspiring stuff. How do you follow that? Well, you follow that with our guest lecture for endourology. It's my great pleasure to introduce to you Professor Ghani from the University of Michigan, where he's been on the faculty since 2013 and leads their endourology program. But in many ways, it's not just welcome to Kirsch. it's welcome back. Because he's a British trainee. He did his undergraduate in Leeds, then his basic surgical training round the corner. I know the distance is up here a little bit larger than for us in London, but he was in Edinburgh. And then his MS and surgical training in London, St George's, and with Ken Anson at St George's, and also at Guy's. And already, having walked around for the last 15, 20 minutes with Kirsch, lots of familiar and friendly faces for him to catch up with. He's the author of 130 papers and has spent, like I did, a little bit of time coming up with some acronyms, including DUST and music. And he'll tell us about music in the second half of his lecture. Compare and contrast the guys that won that race, who came up with the brilliantly original and snappy name, the Dutch Atlantic 4. They spent their time practicing on the river rather than coming up with acronyms as we did, Kirsch. And amongst all of the rest of that, he's an editor and an associate editor of various journals. So definitely a state-of-the-art lecture for us to enjoy. So Kirsch, come and tell us about optimizing stone management from laser settings through population registries and quality improvement. Thank you.
Thank you, Darren, and good afternoon, and what a great honor for the invitation, Darren, and also Jonathan Glass. Thank you very much. These are my relevant disclosures. I am a consultant for 2 medical device companies. I have a research grant with Boston Scientific. A lot of the work I'll be speaking to you about is from that. And then Michigan Urological Surgery Improvement Collaborative is a quality improvement consortium in the state of Michigan that's funded by Blue Cross Blue Shield of Michigan. So Darren is correct. I am a product of British urology, and it's a great honor for me to return here back to this arena. I haven't been back to BAU since I left to the US in 2011, and many of my trainers are in this room. I may have missed some of the people on this photo, but I see Roger Kirby is here. I started my career in urology at the Western General with Alan McNeil and David Tolley. Then I had a very important time with Ken Anson and Uday Patel at St. George's. But I'd just like to take a moment to pay tribute to one individual in particular, and that is Mr. Andrew Ball at Southend Hospital, who encouraged me to do a fellowship in the United States and supported me and was a great mentor to me and countless other urologists. And I'm sad that he's no longer with us, and I wish he was here today. So in my talk, I'm going to divide this into 2 parts. The first section is around how technical aspects around lasers and laser lithotripsy, and in particular the dusting technique, and they're linked. And in the second part, I'm going to talk about the quality of surgery, in particular outcomes, especially related to data in the state of Michigan. Ureteroscopy in North America is now the #1 operation for kidney stone treatment, and you can see from this graph from 1991 to 2010, it's overtaken shockwave lithotripsy, and approximately 60% of all surgical therapies for kidney stones in the States are with ureteroscopy. It's more, my residents do more ureteroscopies than TURP and TURBT combined. But when I trained, it was TURP that was the bread and butter of urology. It's different now, flexible ureteroscopy. But we're not as good as we think. The results for ureteroscopy, especially for kidney stone treatment, if you look really hard, are not that great. And if you look at CT-based follow-up, the complete stone-free rates for kidney stones approach only 65%. And it doesn't matter which technique you do, but dusting technique has become very popular recently in the last decade. And when we did this survey in 2015 and surveyed worldwide endourologists, 60% of them said that they use low pulse energy and high frequency to break stones into powder. And it was surprising that 40% of them had access to high power systems. And it's these high power next generation Holmium systems that have been released that really led to a renewed interest in laser lithotripsy techniques. These surgeon-specific settings, dual pedal features, and very high frequencies that are allowing us now to improve, in my opinion, the quality, the technical quality of this operation. And there's a real great interest around dusting because there are some big advantages in the appropriately selected patient. Patients can avoid a urethral access sheath, they can avoid a basket, and in some cases they can avoid a urethral stent. And already the EDGE study from the United States has shown that if you dust, it's 50% the reduction in operating room time. And in the United States, operating room time is around $60 a minute. But there's really an important aspect around dusting technique, and that's quality of life. Avoiding a stent has significant implications for the patient. And it's in part 2 that I'll touch upon that. So before I delve into laser settings, I think we need to understand fundamentally what happens to a stone as you break it up with laser lithotripsy. Energy cannot be created nor destroyed. And what happens is a lot of the energy is ablating the stone. A fair amount of it is going into the fluid because there's fluid absorption and it's heating the fluid. A good proportion of it is leading to stone displacement, and that's retropulsion. And a very small amount is energy transferred to light, known as sonoluminescence. I want you to remember those 4 things as we go through and understand why we choose particular laser settings. When we do dusting technique, just as we heard from the previous talk regarding strategies on eat, sleep, there's a schema for everything in life. And so for us, there's a strategy, and it starts with preoperative planning with a CT scan, stone density, volume, location, and then we go on to 2 particular stages: contact laser lithotripsy followed by non-contact, otherwise popcorning. And the whole purpose of contact laser lithotripsy is to break the stone, debulk it in one entity, and then it ends up crumbling into a calyx where we popcorn. And popcorning is a really important technique if we're going to get stones broken down finely. So this is examples of contact laser lithotripsy using various settings in the kidney, breaking up the stone, interrogating it, brushing it, getting it smaller and smaller. And you can see that the results look pretty good, especially on the far right. You can see that most of the stone that's being ablated is powder. It is being vaporized. But you can see in the middle screen that there's issues with vision. And I think vision is going to be a major issue as we go forward with advanced lasers and dusting. And then, as I said, what will happen is it'll crumble into a calyx, and then you intermittently fire the laser in bursts, breaking the stone systematically into smaller and smaller pieces. And whether you use a low watt setting, such as 1 joule and 20 hertz, or a high power setting, such as the other ones that you see on the screen, that is based on what access to lasers you have and what your philosophy is. So I'm going to take you through laser settings, and I'm just going to explain 5 basic parameters, and they all impact stone fragmentation, stone retropulsion, and laser fiber burnback. 3 performance characteristics. So the first thing is pulse duration. Then I'm going to take you through pulse energy, pulse frequency, and now the newer pulse modulation on this particular machine. It's the Moses technology, but more pulse modulation systems will be released in the next few years. And the final thing to discuss is total power. So this is a typical holmium laser pulse. This is the anatomy of the pulse. You can see a sharp peak. It's known as a shark's fin. And then you have a duration. It can vary from 200 microseconds to 1,200 microseconds. And then you have the area under the curve, which is the peak power, the maximum optical power of a pulse, which is defined as the pulse energy by the pulse duration. And the peak power is a very important concept, because peak power is the difference between a long pulse duration and a short pulse duration. You can see the videos here. Look at the short pulse bubble. It's much bigger. It has a much more profound impact. Look at the long pulse bubble. It's narrower. Its impact on the fiber tip is much more gentle. And it's this peak power intensities between the 2 pulse that allow us to choose it for the appropriate reasons. And in particular, long pulse duration lasers provide lowest retropulsion, as you can see in these high-speed imaging labs. And also, it is the most safest on the laser fiber tip. So long pulse duration leads to less retropulsion, lowest fiber burnback, and it's debatable whether it leads to the greatest dusting effect, but there's no data to say that, so I haven't been able to provide that to you on a slide. Pulse energy And the relationship with pulse energy is very simple, as you can see in these videos. The higher the pulse energy, the more the ablation, but more retropulsion. And retropulsion, as we remember from that fundamental model, is wasted energy. But it's the low pulse energy that leads to the lowest retropulsion, the smallest ablation, but the lowest retropulsion. And it's the exploitation of the low pulse in the era of high frequency that allows us to do dusting technique. This is seminal work from Joel Teichmann's group in Vancouver that showed that the lowest pulse energy, regardless of stone composition, lead to the smallest chip. And it's these small chips that you're aiming for when you do a dusting technique. Pulse frequency increases your fragmentation. So going from 5 hertz to 10 hertz, as demonstrated by Glenn Preminger in 1998, increased your fragmentation rate. In the modern day, 0.5 joules, when we go from 20 hertz to 60 hertz, it increases our fragmentation rate. So high hertz does increase your fragmentation, but the keen ones in the audience will see that the difference between 40 and 60 is not that profound. And that's because there's probably a saturation point where we're not going to see as much benefit from these super high frequencies. Nevertheless, at 50 hertz, 60 hertz, 70 and 80 hertz, and the appropriately large stone, one can interrogate the stone with a contact phase procedure using maneuvers such as dancing, chipping, painting, to debulk the stone and to be systematic in getting it shrunk down. And I think the big advantage about dusting is it allows us to start that way, but at the end, some of us may then proceed to retrieval, which is the hybrid approach that doctors, well, I should say, I'm in the US, so I'm always used to saying doctor, but Mr. Smith has coined the term dust menting. One thing to remember about these settings, it's very dynamic. So the stone starts off large, and as you break it down, you then have to change your settings. So in this case, if you see a wobble, you have to then reduce the hertz, or you have to reduce the pulse energy. I want to move on to the next phase of laser lithotripsy, and that's popcorning. Non-contact laser lithotripsy, as described by Demetrius Bagley many years ago, because you're firing the laser off the fragments in a calyx, slowly, intermittently firing those pulses. And in the era of high-frequency, high-power systems, we were very interested in understanding what was the best laser setting. And so in this video of high-speed imaging, we see some differences. And so number one, being close to the stone, as you see in the right-sided video, leads to the greatest powder. So that leads to the greatest sub-millimeter fragmentation effect. So the closer you can get your laser fiber on the stone, it's not heating fluid unnecessarily, you get breaking up the stone. The second thing is high hertz, such as 80 hertz, and high power settings are the best. The next thing is, in general, all of these high power settings lead to high powder, and we will touch upon power shortly, but they give you the greatest sub-millimeter fragmentation. However, if you're doing popcorning in a large Kähler seal model, such as you see here, no matter what settings you use, the results are not great. And that's why when we do popcorning, we select our calyx where we pulverize the stone. And we've been using a setting of 0.5 joules at 80 hertz, a 40-watt setting that we've been calling pop dusting. And we found, both in the laboratory and in clinical practice, this breaks up the stone and leads to the finest fragments, as you can see in the video where it's working. And in that patient had a CT scan and they were completely stone-free. But in the other patient, it didn't work so well for various reasons, more dilated calyx, slightly harder stone, where we had to do a hybrid technique. The new technologies are pulse modulation, where you're getting a double bubble, where the, and I don't know if this video will play, but if I go back to that prior slide, go forward. What you see with the Moses pulse modulation is you get a double bubble, and this second bubble, energy is being transmitted to the second bubble, and the first bubble is taking in the fluid because there's a certain amount of fluid absorption. So you're optimizing energy delivery. And what we found in the laboratory is that these new pulse modulation mechanisms lead to more fragmentation. And in fact, we got around 30% more fragmentation when we broke a stone in a controlled laboratory environment. And if this video played, you'll see the differences in the double bubble in controlling retropulsion. And again, retropulsion is wasted energy, and if you can reduce retropulsion, you'll make yourself much more efficient. And another important aspect about pulse modulation, and I don't think these videos will play, but is that it works at distance. And so because of that two-bubble phenomenon, you're able to deliver more energy, as you can see in that graph, to the stone at 1 millimeter away. And that's really important because how many of us are always touching the stone? We don't know during laser lithotripsy. It's an active process. So with pulse modulation mechanisms, you're ablating the stone much more efficiently when you're away and also when you're on contact. And so these are some current knowledge gaps that we have in the field. We have this tension between material absorption and fluid absorption. If we have great material absorption, we have too much dust and we have bad vision. And then we have to increase the flow rate. And that has safety consequences in terms of intrarenal pressure. And then in terms of fluid absorption, you've shown high power settings. What is that doing in terms of heat? And is that causing any damage to the kidney? And so on that, I'd like to transition to the last parameter, and that's total power. So we've gone from an era of fragmentation where we did 8 and 8, 6.4 watts, to increasingly higher and higher energy. So, and in a study from our group showed that when you use 40-watt settings and you fired the laser for a long duration, you would get heat effects up to 70 degrees Celsius, and there can be thermal damp toxicity to the renal tissue. So high power settings can generate heat, which can be injurious. And that's one take-home message, is that we do not advocate high power settings when we work in the ureter. We recommended low power settings, and the technique is slightly different. We work centrally versus peripherally for obvious reasons. But with great power comes great responsibility. And the current strategies that you have to consider when using high power in the kidney are you have to regulate your laser bursts, what's called the operator duty cycle. You have to use higher flow rates, as we've seen. We can use urethral access sheaths to improve outflow drainage. We can use chilled irrigant. I think some of you might be using warmed irrigant, and in the era of high power settings, maybe that has to be, you have to reconsider that approach. There can be active suction, and overall, we can do other strategies to improve the efficiency of laser fragmentation. And so we are going to move towards an automated future in this field. We've done work on understanding visual detection of stone composition using visual recognition features. And I think digital endoscopes will speak to the laser platform. It will work out the stone composition. It will optimally give you the setting automatically. And we will have automated systems that will put irrigation and suction and control both the temperature and the intrarenal pressure. This is inevitably the future of where laser lithotripsy is going. So, in summary, dusting technique offers the option of stentless ureteroscopy. Long pulse reduces retropulsion and limits fiber tip degradation. Low pulse energy results in the lowest retropulsion and fragment size. Higher frequencies lead to more fragmentation. Keeping the fiber on contact with the stone results in the greatest fragmentation. New advances such as pulse modulation improves fragmentation, especially at distance. And for popcorning, high power settings result in the highest powder. However, high power settings may lead to heat generation, which needs to be mitigated. So on the second part, I'd like to talk about stents and ureteroscopy in the kidney and what impact they're having on a population level. I explained to you, ureteroscopy is the #1 operation. In the United States, we spend more money treating kidney stones than we do prostate cancer. And one of the things that the UDA group based in Mark Littman and Chuck Scales recently looked at is the costs for ureteroscopy and shockwave lithotripsy. And they found that 1 in 6 patients visited the emergency department within 30 days after a simple ambulatory procedure like ureteroscopy. And they concluded that interventions are needed to identify and reduce preventable unplanned visits. We looked at this in the state of Michigan. My colleague John Hollingsworth looked at payments for ureteroscopy, and we found that the average payment was around $11,000, but there's a wide variation in payments depending on the hospital. And what we found is that if you had a ureteroscopy using claims data, and then you had an unplanned visit to the emergency department, costs went up by 50%. If you were hospitalized, costs went up by another 100%. And these unplanned encounters are costly. They're costly to the payer, and they're also troublesome for the patient. So in the state of Michigan, we have a statewide collaborative. We have around 45 practices that all share data, look at best practices. The whole point is to understand areas of performance, look at exemplary performance, and see what strategies can then be implemented throughout the state to improve care at a population level. And it's been around since 2011. It started as a prostate cancer initiative led by my colleagues David Miller and Jim Monty, but we've now expanded it into kidney stone care. And we've developed a collaborative called Reducing Operative Complications from Kidney Stones, and another acronym, as Darren kindly said. And our vision is to make Michigan the safest place in the world for kidney stone care. Our initial goal has been to reduce these unplanned encounters after ureteroscopy. So how do we do this? It's not simple just to collect data. We have to collect the data to improve. So this is a schematic of our architecture. Every practice has a trained abstractor. We pay the practices to put standardized, high-quality, audited data into a prospective clinical registry. We have a champion in every practice whose job is to be the boots on the ground, get the troops going, to improve care and bring in the processes into that practice. We have patient advocates that tell us what matters to them and what we should focus on in terms of kidney stone care. And we try and choose these projects based on patient advice, member advice. We meet 3 times a year where we go through all the projects, look at the data, and then develop implementations. And so our philosophy is to use the data to inform action that then goes back to making feasible change in the practice, real-world practice. So this is a snapshot of what's happening right now in the state of Michigan amongst all these practices doing ureteroscopy. You can see 36% access sheath use, 57% are doing retrieval, 72% are doing overall stenting rate, and you can see that the stone clearance rates, like I said before, 61% for kidney stones, but much higher obviously for urethral stones at 94%. And this is what's happening in the state when we look at 21 practices. When we last looked at this data, nearly 7,000 ureteroscopies in our registry. We now have 15,000, but at this stage I just want to present this data, and you can see the variation in outcomes. Why is practice 1 got a 0 ED visit rate, and why does practice 21 have the highest rate at nearly 16%? What is practice on the far left doing that we can learn from so that the practices on the far right can adopt? And we found that a lot of these visits are occurring in the first 7 days. And this is the reasons for the visit. And most of the visits, around 40%, are related to pain, hematuria, urinary symptoms, stent-related symptoms mostly, where 70% of these patients had stents. And we found that on multivariable analysis, the use of a urethral stent was highly significantly associated with an emergency department visit. And if we look at our data over the last few years, these modifiable rates of these visits for pain and hematuria are stable. They're around 30 to 40%. So these patients will present to the emergency room, they'll be fully evaluated, they'll get a CT scan, they'll get labs, they'll get all sorts of things, and they'll go home. And it's the stent or it's just symptoms related to the surgery. So what can we do to modify that and to reduce these unplanned encounters? Well, this is a schematic that gives us an overview of what we can target. We can educate patients better about what stents mean and what to expect with stents. We can avoid stents in the first place, and that's why I pivot back to the part 1 where dusting technique offers that opportunity in the select patients. And we can do much more in terms of understanding their quality of life and other aspects regards to improving symptom control with better medication. So the first thing we've done is we've developed a very stent-specific patient education leaflet with our advocates, with our members. It's available on our website. Anyone can use it. And we've been inputting that in all the practices, and it's been a big part of the drive just to set expectations. There was one study from Switzerland recently that showed that patients who were better informed had less symptoms. The second thing is we've developed guidance on improving symptom control. In the US, it's been very common to put a lot of these patients on opiate medication, and what we've pivoted towards is non-steroidals, alpha blockers based on guideline-based care, and also anticholinergics for those who have a stent. And we've also created patient education leaflets around this so patients understand why they're getting these medications and that they don't need opiates, but there are better targeted drugs that will improve their symptoms after this operation, because this operation has symptoms. And the last thing that we've done is we've instituted performance feedback. Practices get aggregate data on how their emergency department visit rate is doing. Physicians, I get a quarterly report of my performance, how many ureteroscopies I've done, what my stone-free rate is, what my emergency department visit is, what my imaging rate is, what my use of alpha blockers is, you name it. It's fascinating for me. And we can go back and look back at why our patients got sick. And we rely a lot on physicians and their own inner drive to do better. But we do have to also develop strategies around the whole wide state to drive improvement in care. And I'm not saying that we've won, and I'm not saying we're winning, but this is just an assessment of the last couple of years of those emergency department visit rates. We've seen somewhat of a reduction. I don't know if it's just we're collecting more data, and I don't know if it's just the Hawthorne effect of everyone now knowing that this is a drive to improve care, that we have a mission around this. But we are seeing some signs of an early success, although we have to give it a little bit more time. But I would say that we are very focused on two future strategies. Is that one of the things that we're going to look at, and if you look at that graph, you can see this is our pilot group, and we started ROCS. One practice is doing 40% stenting, and on the far right, around 100%. So why does one practice stent less and the other one stent more? And so we're developing appropriate use criteria for ureteral stenting after ureteroscopy in the state. That's a big initiative that we have planned. And we're also going to be developing a patient-reported outcome system to better understand quality of life and the patient's perspective. So I go back to this. Dusting technique has major advantages in the appropriately selected patient, and that is to reduce the use of routine stents. And as you've seen from our work in the state of Michigan, ureteroscopy and stents in particular have significant healthcare economic implications. So in summary, the emergency department visit rate is an emerging quality indicator for ureteroscopy and laser lithotripsy. Overall, in the state of Michigan, we found that 1 in 10 patients visit the emergency department within 30 days, but variation exists in outcomes. Nearly 40% of these visits are due to pain and stent-related symptoms, and they're potentially modifiable. But measurement is not enough. In music, we've been collecting the data, providing outcomes, understanding best practices, and designing interventions to improve the quality of stone surgery. Our initial quality improvements efforts are to educate patients on what to expect and better symptom management. And we hope that this will have an impact in reducing emergency visits in the state. It's a huge effort, just as you saw from the tough lecture, that it's a team approach, and I'm just a messenger for our group. So many hardworking people that I represent. I want to acknowledge everybody in the picture here, David Miller, Jim Monty, my colleagues in ROCS, Casey Dow, John Hollingsworth, and of course our patient advocates. I also need to acknowledge our laser lithotripsy team at Michigan for the work that I presented, which is a multidisciplinary group between urology, engineering, and chemistry. And I also say that we have a course that we run every year in Chicago, and I said to Darren that we are going to give free registration to any BAUS members who register using the code BAUS, but there's only 10 free spots, so the first 10 free. So please, if you're interested in understanding more about laser lithotripsy, come to our meeting in August. And finally, a plug for this meeting at the AUA in December, which is a collaboration between the AUA and Endourology Society, where we're going to be discussing outside-the-box ideas for improving kidney stone care. So on that note, I thank you very much for your attention and the opportunities to speak. Thank you.
Well, Kirsch, thank you very much for that tour de force. We started marginally late, but that was a brilliantly delivered and perfectly timed lecture to take up that half-hour slot. So we won't have time for questions now because there's something else on the programme. But as you would rightly expect, for 10 free places at Kirsch's meeting, we're getting our money's worth out of him here. He'll be around all week. He'll be chairing one of the Stone sessions tomorrow, doing the Stone course. So if you want to catch up with him, ask him anything, or coin your own partial acronym like maybe paint dusting or dust popping, that's possibly even illegal, catch up with him in the next 48 hours and have a chat with him. Kirsch, thank you very much. That was excellent.
Resume 4-year data. This is the results from the US pivotal study, the study that was set up to basically allow it to have FDA approval in the US. So I'm going to take you through Resume in about 12 minutes and try and incorporate my experience of this technique. So I would say that Resume is a welcome addition to the expanding portfolio of minimally invasive treatment options for BPH. Fortunately, I think going are the days when patients were only offered a TURP as their option. The world is changing. Patients have a greater awareness of what's going on, or the majority do. Social media helps with that. And increasingly men are informed and looking for alternatives to medication, or not getting on with medication and looking for a minimally invasive treatment, which would be something less severe perhaps than a TURP. They want a favorable side effect profile. They want perfection, really, but we obviously as clinicians have to make sure that we are appraised of all the latest data and that we give the patient good information and enable them to make an informed decision about what option is best for them. My view is that the new gold standard isn't a procedure, it's a portfolio. As we move away from just TURP to there being options, laser therapies, Urolift, prostate artery embolization, etc. But I'm here today to present the Resume 4-year results. So let's just move on. So how does it work? So essentially, I think it was 23 years ago that I stood here at Baus as a research fellow in urology working in Brighton, and I presented the interstitial radiofrequency therapy versus TURP 2-year outcome data. It seems like a long time ago. That was obviously a thermal therapy, and there have been many others interstitial thermal therapies. But the difference, and one of the key messages for me to get across to you today, is that this is not delivered by conductive heating, this is convective heating. And so it's the unique properties of the delivery of steam in what is essentially low pressure, albeit higher than interstitial prostate pressure, steam delivered into the prostate gland, and it's confined to the space or compartment into which it's injected. So you'll see from the slide there, what, sort of before and after. What's happening is the handpiece goes sort of naked down the urethra. There's no outer sheath, so it's a narrow caliber handpiece. It's obviously been refined, and the optimal delivery is at the temperature is 103 degrees Celsius. The steam that is injected into the prostate gland, it's a 0.42 mil water droplet that's heated up by, it's a radio frequency generated steam delivered into the interstitium of the prostate, into the transition zones and the central zone. So when faced with a case, what one needs to know is the size of the prostate gland, and one would assess the length of the prostate gland. I always do a truss volume, ideally when I see the patient in outpatients, but also at the time of the procedure. It would give me a clue as to what the prostate looks like in the sagittal plane. Is there a prominent median lobe? Are there any surprises? Occasionally one picks up Mullerian duct cysts, etc., and other things. So the ultrasound sort of gets me thinking about the case, and then I go on with the handpiece, deliver a number of treatments which would correspond with what was required. So the bigger the gland, the more treatments that are required. Each handpiece delivers up to 15 treatments, and that would, I've never had to use a second handpiece. And the range of glands that certainly in the US pivotal study that were treated were those with a gland volume ranging between 30 and 80 mils. Just to say a bit more about the procedure, in the US it's performed in the office, but I think in the UK it's still very much a day case procedure. It can be performed under general, of course, but also local anesthetic with sedation. We've refined what we do, and we tend to give remifentanil and midazolam, but and as well as topical chilled instiller gel. It is a little bit more uncomfortable just for the period of the steam delivery than, let's say, the Urolift procedure, but the patients are very comfortable within moments of the procedure finishing. It takes 5 minutes of endoscopic time. Procedure time is overall in the order of 15 to 20 minutes. It's very easy to learn, and the learning curve is reasonably short. So just to go into the Pivotal 2 study, the results that I've got to let you know about today, what they show is that overall at 4 years, a 10-point reduction. The primary outcome measure was at the IPSS score pre and at 3 months. That was the primary outcome measure. And essentially, there was a 10-point IPSS reduction, a 4.2 mils per second improvement in the maximum flow rate, and a 2-point reduction in the quality of life, and the BPH impact index reduced by 3.5 points. These were a population of men with IPSSs of 13 or greater, gland volumes between 30 and 80 mils, no obvious infection. PSA, I think, had to be under 2.5. So a very sort of clean cohort of men going into the Pivotal 2 study. They were randomized 2 to 1, 197 men across 15 centers in the US. Those that had the sham treatment with no steam delivery were then offered to cross over and have the real treatment. And these are the results out to 4 years. If we look at the IPSS, so the IPSS reduction is at its greatest at 3 months, a slight but steady rise out to 4 years. So IPSS 22 pre-treatment on average 11.4 at 4 years. And the Qmax, you'll see there, as I mentioned earlier, pre-treatment, the average was 9.9, peaking at 3 months at 16.1 mils per second, and now the results there out to 4 years. In terms of, essentially, Rezum is a very consistent treatment from the pilot studies done in the US and the pivotal study and my own experience, which I'll talk about a bit in a moment. There is a predictable improvement, a consistency about the improvement in symptoms, and it also appears to be a durable procedure. At 3 years with Rezum, the surgical retreatment rates were 4.4%, and with the latest data, the retreatment rates are still at 4.4% in that cohort at 4 years. So relatively low rates of retreatment. Certainly in my experience, because I've been doing Rezum now for, I think, 2 years and 3 or 4 months, I know it's early days, but we haven't had any strictures to date, so I think that might be one reason for a favorable low retreatment rate as time evolves. Again, just looking at the BPH impact index and quality of life, so looking at the quality of life measures, at the end of the day, this is what's most important. Again, the optimal reduction at 3 months with a slow and very slight rise out to 4 years. Sorry, I thought there was one extra slide. So essentially, just to talk about my own experience. So the results that you've seen here, we're presenting a poster tomorrow afternoon, and we presented the combined Imperial and Basingstoke data on the first cohort of men treated in the UK at last year's BAUS. And I think it's a similar cohort of patients, but obviously this isn't as part of a randomized trial, it's just consecutive patients treated with prospective data collection. So we have some gland volumes that were larger than 80 mils. And essentially, the average gland volume from the pivotal study was, I think, 46 mils. From our series, it was 50 mils. So we're treating slightly bigger glands. Only 30% of patients in the pivotal study had their median lobe treated, and it's at least 50% in the cohort of patients that we've treated. Now, in the pivotal study, those patients had their treatments under local or local with sedation. And I think it is a little bit more difficult to get on and deliver as many treatments as you might want to if a patient is a bit uncomfortable during the procedure. So the difference between the early UK results are that overall we've treated a slightly bigger gland volume. We've put in perhaps one average treatment extra. So for the US data, it was 5 treatments, I think, on average per case. In our data, it's 6 treatments per case. I've used the full 15 treatments about 7 times. In the close to 400 patients that I've been involved with that have had the treatment over the last 2 and a bit years. So essentially, so our average IPSS was similar, I think 21.8 at pre-treatment, falling to a minimum of 6 at 6 months. So we've seen a sort of 15, 16-point reduction in IPSS. We're continuing to follow up that cohort of patients. Our average maximum flow rate was in the order of 6 to 6.5 mils per second. So again, a little bit better at improving the flow rate compared to the US data. And quality of life, our average pre-treatment quality of life was again 4.4, falling to 1.6 at 6 months. So similar, but perhaps slightly better. The reasons for that are, I think, that the handpiece has been refined since the US pivotal study. We are giving all patients sedation or doing them under general anesthetic. We're tending to give a few extra treatments. We're having a low threshold for treating the median lobes because it's very good with the median lobe. And sometimes if it's a very prominent central zone with a sort of steep incline up over and into the bladder, I will treat that central zone. In terms of so 97% of patients have gone home the same day. the reasons for staying overnight have been just to do with some patients have had an anaesthetic, or there's been nobody at home, or in a small number of cases they've had bleeding that's required an overnight stay. In terms of managing patients for Rezūm, as I said, it's a very durable and reliable treatment, and at the end of this, there is no harm. We've had no patients with new pad usage. We've had no patients reporting new ED. We've had a small proportion of patients reporting drier ejaculation, but a similar proportion reporting improvement in ejaculatory function. And overall, in the US and the UK data, there has been no, using all the appropriate PROMs, there's been no statistically significant deterioration in sexual function using all measures. So the patient, it's a low-risk procedure. The downsides are that the patient does have to be patient because it's an interstitial treatment. The zones, each little treatment will ablate a volume of prostate tissue. It'll be confined by the pseudocapsule of the transition zone. And so that lesion, or those lesions that are created, will need to gradually resorb and disappear over time. But what they don't do, which is another key difference to the conductive heating techniques, is that the tissue tends not to discharge itself through the urothelium of the prostatic urethra. Each of the little treatments is made with a little tiny needle puncture. And so I think there are areas, small areas, where you do get some of the urothelium becoming non-viable, but the vast majority of it maintains its integrity. Perhaps with the median lobe, it's a little bit more likely that the patient will produce a little bit more debris afterwards, and I do warn them about that. In terms of catheterization time, so one of the downsides compared to some of the other minimally invasive treatments are that the patient does have to have a catheter afterwards for about 3 to 5 days, but this does depend on the size of the gland pre-treatment and, of course, the patient age and other factors too. So I'm just going to come to the end of my talk and just really summarize and say I think this new treatment, relatively new treatment for BPH, is not a flash in the pan. I think I would encourage you all to consider bringing it into your practice, whether or not you should look at UroLift and Rezūm, or one or the other, or I think that's up for discussion. But patients deserve to have options other than TURP and medication. I really have been impressed with the results thus far, and our results do seem to mirror those from the US pivotal study. I think I've been told that not to have questions, because I think there could be an awful lot of questions, but I will be on the Boston Scientific stand between 11 and 1 tomorrow if you do have any questions. So I hope that was helpful. I've certainly been impressed with the results thus far, and I would really urge you to give it some consideration and adopting it into your BPH practice. Thank you very much.